Hello, my name is Veronica Chang. I'm one of the neurosurgery faculty here at Yale. I'd like to thank the organizers of the RSNA for inviting me to speak today. I will be speaking on the use of LIT for the management of brain tumors. Before I start, here are my disclosures. So the original title of my talk was Surgical Planning, Image Guidance, and Extensive Resection, and Surgical Alternatives, including LIT, for managing brain tumors. This is a huge topic, and so in the 15 minutes I have today, I'll be mostly talking about LIT. But I wanted to start by revisiting some of the basic premises of surgical planning. So traditionally, the goals of most surgical cases of brain tumor involve firstly obtaining diagnosis, and then secondly obtaining relief of neurological symptoms. And so this first scan was from a 50-year-old female who presented with confusion and episodic speech arrest. While we obviously only have the gadolinium images to look at here, the differential diagnosis on this lesion could include metastasis, glioblastoma, or less likely lymphoma. Extent of resection then is firstly dependent on pathology. If at the time of frozen section pathology was consistent with lymphoma, then an argument could be made to not resect the entire tumor. Given the large amount of mass effect on the local cortical structures as well as midline shift, however, regardless of the pathology, it is more likely that resection of as much of this tumor as possible would be beneficial for relief of neurological symptoms. Extent of resection is also dependent upon the efficacy of adjuvant therapy. And so the reason for not necessarily removing all of this tumor is that if it's lymphoma, then CNS lymphomas tend to be very responsive to chemotherapy with or without radiation. In contrast, the original studies in the early 2000s by Sawaya and his group at MD Anderson are often cited showing that resection of greater than 98% of the glioblastoma gives the patient a survival advantage. Temodar, however, was not approved until 2005, and MGMT promoter testing and use of Avastin did not come on board until 2009. And so today, extensive resection may play a role in some glioblastomas, but not all. On the other hand, we do know, based on Simpson grading, that complete resection of a grade 1 meningioma, as shown in the top left, results in best long-term local control, as well as for vestibular schwannoma, as shown in the bottom left. Whereas for a brain metastasis, on the right, 70% of these will regrow if not treated with adjuvant post-op radiation. The last factor to consider in extent of resection is functionality, which is unique to the central nervous system. And so in these three examples of temporal lobe lesions, the ability to map functionally critical speech pathways determines extent of resection. In the first patient on the left, the arcuate fasciculus is clearly demonstrated to be pushed posteriorly and superiorly, allowing complete resection of this lesion. In the second case in the middle, while the enhancing portion of the lesion is far anterior in the temporal lobe, the region of T2 and flare signal abnormality clearly resides in and expands the superior temporal gyrus. And so this transforming low to high grade glioma is unresectable. And in the third case to the right, it can be seen that word generation pathways originate and traverse the posterior aspect of this lesion, and therefore an anterior approach is needed for resection of this lesion. So far, we have talked mostly about large and surgically accessible lesions. What about lesions like these? So all of these cases were symptomatic and could potentially be surgically resectable. But the first three, starting from the left, resection would come with considerable morbidity or risk due to the parts of the brain involved along the access route. And the fourth case would put language function at risk. And in addition, not everybody wants a craniotomy. And so I'm going to spend the rest of this talk on a whirlwind tour of a new surgical technique known as LIT, which stands for laser interstitial thermal therapy, or a combination of laser causing thermocoagulation. Conceptually, the use of heat for ablation of tumors or the creation of functional lesions in the brain using heat is not new. The biggest challenge has always been the ability to control heating size and minimize surrounding collateral injury. And so the principle behind the laser is that laser light at a wavelength of somewhere between 800 and 1100 nanometers per second is emitted from a source, and as it hits the tissues, it is either reflected, scattered, or absorbed. Absorbed light then turns into heat, and how much light is absorbed varies by tissue type. What is unique to LIT is that it is MRI guided using MR thermometry, something that I'm sure you're all familiar with and originally was described by Ferenc Ulaz in the early 1980s. And by taking raw, sequentially obtained gradient echo MR thermometry data and feeding it real-time into processing software that uses the modified Arrhenius equation, a real-time visual map estimate of the area of tissue injury can be created. The laser can then be turned off when the area of heat encompasses the target lesion. So to walk you through a case, this is a 42-year-old female with known metastatic melanoma. She is typical of many of the cases done today using LIT. The patient underwent radiosurgery to a presumed brain metastasis seen all the way to the left. The lesion initially responded to treatment, as can be seen at 3 months, but then started to regrow at 12 months. And as you all know, the differential diagnosis here would then include regrowing tumor versus radiation necrosis. And PET, as you can see, showed that it was more likely to be tumor. So the standard options for treatment at this time would be craniotomy, repeat radiosurgery, or whole brain radiation therapy, none of which were considered great options. So the patient was taken to the operating room where through a 5mm stab incision in the skin and a 3mm twist drill hole in the bone, a needle biopsy was obtained and confirmed regrowing tumor. The needle was then taken out and the laser fiber was then introduced along the same trajectory, and the patient was then put into the magnet and a T1 image confirmed laser placement. What you can see here, because I can't get the video to work, are red lines on the bottom that show the scan planes for MR thermometry, and then the light blue line outlines the lesion. And so the yellow line, which grows over time, is the estimated tissue treatment line. And when the treatment line encompasses the edge of the tumor, then the laser is turned off. As with all MR imaging, data acquisition is rarely perfect. Images are affected by proximity to bone, air, blood, and sometimes for no comprehensible reason at all. And so, often the aggregate treatment lines are incomplete, which makes the ability to guarantee complete treatment currently impossible. But this is an image of completed treatment. For the patient, though, this is a fantastic procedure because their incision is small, there's very little pain, and therefore hospitalization is short. And so for the successful case, this is what we typically see on imaging. Somewhere between 24 hours and 2 weeks after LIT, T1 imaging with gadolinium will show an area of enhancement larger than the original lesion, but with this very clean eggshell border of enhancement, an early decrease in perilesional edema that you can see labeled here as 2 weeks post-LIT. Then over the next 3 to 6 months, there is further decrease in the size of the lesion and the amount of surrounding edema. What's important to note, particularly on the 3 months post-LIT imaging, is that rate of resolution around the lesion is not equal. And so some nodularity can be seen at 3 months, which resolves by the 6 month scan. And so this is in comparison to the second case, where while we see the same eggshell lesion at 2 weeks, the resolution of the edema seems less pronounced, and by 3 months we can see more irregularity along the border. Certainly by 4.5 months, it was obvious then that we had missed some part of the tumor. The indications for use of LIT are evolving. In the tumor literature, any growing deep-seated tumor that is less than 3 centimeters diameter is now fair game for LIT. In our institution, this list of the tumors that we most commonly treat with LIT. Because of the small incisions and there being almost no blood loss with these procedures, we have started using LIT particularly for pediatric patients with lesion-related epilepsy. And so I thought for the rest of the time that I had, I would just run through a few cases to show you some of the successes we've seen. So this first case is a 48-year-old female with lung adenocarcinoma with a tumor PD-L1 level of 50%. She had previously undergone whole brain radiation therapy in the past and now was regrowing multiple new brain metastases. And so you can see the complex radiation treatment that she had to undergo on the left. And of the 23 tumors treated with radiosurgery, the one in the right basal ganglia started to regrow at 9 months while on immunotherapy. Because of the amount of edema that was associated with this lesion, she was symptomatic and had to be started on steroids, and so immunotherapy had to be put on hold. We treated her with LIT, and what you can see on the 2-week post-LIT scan is one of the major benefits of LIT in patients with radiation necrosis, and this is the rapid reduction in perilesional edema in some of these lesions, despite the fact that there was no significant change and maybe even some slight increase in the size of the enhancing lesion. The patient was able to restart immunotherapy 3 weeks post-op and has gone on to survive many years with stability on her scan as seen at 6 weeks. This is another lung cancer patient whose lesion was regrowing after radiosurgery. Given its occipital location, craniotomy for resection would have knocked out his visual tracts and left him with a homonymous hemianopsia. He earned his living as a taxi driver, however, and so instead of doing the craniotomy, we used LIT and were able to preserve the tracts by choosing a more inferior trajectory to access this lesion. Not only did he have good resolution of the lesion and surrounding edema, but he was able to go back to driving full-time after his surgery. This next patient is a 53-year-old male whose initial glioblastoma was resected in December of 2016. He was then treated with standard radiation and Temodar, but unfortunately recurred infraremedial to the original surgical site in September of 2017. He was offered repeat craniotomy, but was reluctant to do so at the time, and so instead we lasered the enhancing portion of this lesion. And so you can see that in November 2017, immediately post-op, we were able to laser the entire portion of the tumor as well as much of the flare signal abnormality. He was then started on Avastin, but unfortunately, as is typical of this disease, it just recurred again at the edge of the treatment area in March of 2019. And so while LIT is not necessarily the be-all and end-all treatment for glioblastoma, laser was able to buy him an additional 16 months of survival, which I think is pretty good given the options. This next case shows that we've actually had better outcomes with focal treatment of low-grade gliomas. So this is a 35-year-old gentleman with a low-grade astrocytoma who was initially resected, as you can see, in 2013, and then he recurred at the posterior edge. By using LIT, we were not only able to ablate the flare area of abnormality, but we also were able to avoid reopening the original incision by choosing a more occipital trajectory rather than coming through the original surgical site. And so this last point has been one of the major benefits of LIT and has allowed us to tackle many cases, particularly of meningiomas that have been operated upon multiple times. So the leftmost case is a patient with NF2 who has actually had many prior craniotomies. By choosing this more unusual trajectory as opposed to the more direct left temporal trajectory, we were able to find a surgically naive approach to this lesion. You can see that we took similar approaches with the other two cases, also with success. And so again, not only did the meningioma shrink nicely in response to the laser, but so did the perilesional edema. And she has gone on to, for 5 years now, to have good local control, although obviously she's developed new problems in other areas. Lastly, because of the minimally invasive nature of the procedure, we've had several cases where multiple lesions can be treated in the same surgical setting. And so in summary, the indications for using LIT are continuing to grow because of its minimally invasive nature. I think it is important to recognize that post-LIT imaging changes can be quite different than those seen post-craniotomy. Not only are lesions expected to be larger post-LIT than pre-op, as seen by the graph in the bottom right, as an aggregate of volume change after LIT, but the complications of access to the lesion can be distant to the usual craniotomy access site for the lesion. And so, as always, interpretation of postoperative changes in context of the clinical scenario is always much appreciated. Before I finish, I'd like to acknowledge the huge team that it takes to help me do these cases. I will end here. Thank you very much for your attention.
Hi, and welcome to my talk on the role of imaging for the prognosis and management in molecular-defined glioma. My name is Marion Smits, and I am a neuroradiologist at the Erasmus MC in Rotterdam, the Netherlands. These are my disclosures, none of which pose a financial conflict of interest to the content of my talk. So let's start with the molecular definition of glioma, which was introduced for the first time in the WHO classification update in 2016. The WHO 2016 classification consists of a layered diagnosis of histology for grading and molecular parameters to classify adult diffuse glioma. The key mutations that are considered are the presence of IDH mutation and the 1p19q co-deletion. By definition, 1p19q co-deleted tumors are IDH mutated. And of course, we've known this mutation since well before this classification as the hallmark feature of oligodendroglioma. In the absence of a 1p19q co-deletion, we're dealing with an astrocytic tumor, which is either IDH mutated or an IDH wild type. So histological grading is added to this as we know it from before the WHO 2016 classification. This classification is a true improvement over that of histological grading, is exemplified below here in the survival curves for several tumor types. So in yellow, we can see the oligodendroglioma, in red, astrocytoma, and in white, the glioblastoma. So with either histopathological or molecular classification, you can see that survival is best with the oligodendroglioma and worse with the glioblastoma, and intermediate with the astrocytoma. However, it is also apparent that these differences in survival are much clearer if the tumors are classified on the basis of their molecular profile rather than histopathologically. In recent years, it has also become clear that the prognosis of grade 2 and 3 tumors is more defined by their molecular status than by grade. This is most striking for the IDH wild-type tumors, which even as a grade 2 or 3 tumor have a very poor prognosis, which is comparable to the highly aggressive glioblastoma. So this and other insights have led to further modifications of the WHO 2016 classification by the See Impact Now working group. The modification that I'm showing you here is the 5th update from this working group, and this will most likely be incorporated in the upcoming revision of the WHO classification this or next year. And I'll take you through the main differences with the current classification. So first, to be more in line with other WHO classifications and also to reduce errors, the grading is now noted in Arabic rather than Roman numerals. More importantly, a very clear distinction is now being made between IDH mutated tumors and IDH wild-type tumors with other mutations such as gain of chromosome 7 and loss of chromosome 10, TOT mutation and EGFR amplification. This latter group is now considered an entirely separate entity and, irrespective of the grade, are called glioblastoma. IDH mutated tumors are then, as they are now, further classified according to their 1p19q co-deletion status, differentiating them between oligodendroglioma and astrocytoma. And note that there is a proposal to now no longer consider glioblastoma as a term for IDH mutated tumors, but to use grade 4 astrocytoma instead. So to move to the role of imaging for diagnosing these molecularly defined subtypes of glioma. So while formally there is none, imaging plays no role in the molecular diagnosis and as such the management of glioma. The diagnosis is based on tissue, so biopsy or resection is always necessary for further management decisions. Informally though, your opinion is always asked. This is the same with the grade. And this is, of course, also a tissue diagnosis, but we're always in every brain tumor group asked whether we think the tumor is high or low grade. And this does sometimes affect our clinical decision making. So future prospects are that the role of imaging will be more formally included in the decision making, especially for challenging cases such as patients with a poor performance status and a tumor that is obviously a glioblastoma. So maybe one day our imaging and image analysis are good enough to obviate the biopsy that is solely used to obtain tissue for diagnosis in these patients. Conversely, you can imagine that in some patients, a watchful waiting approach is used based on imaging characteristics. But to stress, this is at present not the formal role of imaging and will probably require that we improve our diagnostic accuracy further. What's potentially an even more interesting role that we can play is to assess the molecular heterogeneity and changes over time. And we can't keep biopsying patients time and again over time, while of course imaging is non-invasive. And this is specifically also interesting for selecting patients for clinical trials that investigate agents that specifically target certain molecular profiles, and where, again, we don't want to re-biopsy them just to include them in a trial. So as an example of where we as imagers can already play a role, this is a case of a 57-year-old female presenting with seizures and progressive neurological deficit. She has multiple non-enhancing lesions. Overall, this doesn't look particularly aggressive, but note that there is an area of increased perfusion, and this prompted urgent biopsy. So this came back as a astrocytoma grade 2, but note that the next generation sequencing showed an IDH wild-type tumor with PTEN mutation and EGFR amplification, so a profile consistent with glioblastoma and consistent with the increased perfusion that we saw as an indicator of biological aggressiveness. So what are the imaging features that we have to classify molecular subtypes of glioma? Let's start with the 1p19q codeletion. So these are the imaging features that we're already well aware of, consistent with oligodendroglioma here on the right. So note the indistinct border, the frontal lobe location, and the heterogeneous signal intensity. Compare that with an 1p19q intact astrocytoma here on the left, with a very smooth, well-defined border, a preferential temporal or insular location, and very homogeneous signal intensity. Also, don't forget the other hallmark feature of oligodendroglioma, which you can easily miss on MRI, calcifications. So CT can be really so helpful in these cases where the tumor looks really wild on MRI, and CT will basically help you with the diagnosis of oligodendroglioma. Another feature of oligodendroglioma that we sometimes see is that there may be moderately increased perfusion, even in the low-grade tumors. And this is due to the internal vascularization of oligodendroglioma, which we can also sometimes see as pontiform enhancement. So let's move to the IDH mutated astrocytoma. So here we talk about the 1p19q intact tumors, so the astrocytomas, and another helpful sign here to distinguish these from the 1p19q co-deleted tumors is the T2 flare mismatch sign. So this is shown here on the left, where the tumor is very bright on T2 weighted imaging, and there is a signal loss on the flare weighted image or the flare imaging with only a hyperintense rim. Compare this with the case on the right, where we have an unusual location of oligodendroglioma in the temporal lobe, but we don't see this T2 flare mismatch. This T2 flare mismatch sign has a very high specificity, but unfortunately it isn't always there. So what about the higher grade tumors, the grade 4s, or what we used to call the glioblastomas? Can we distinguish those from the IDH wild-type tumors? So the most striking finding in IDH mutated glioblastoma or grade 4 astrocytoma is the very large non-enhancing portion of the tumor, in this case very nicely illustrated with just a very small enhancing nodule. And this is really a typical IDH mutated high-grade tumor, in this case a grade 4. The best MR or non-invasive marker is for IDH mutation, of course, is 2-HG, 2-hydroxyglutarate. This is the result of aberrant conversion in the citric acid cycle and can be considered an oncometabolite. The beauty is that this can be detected with a dedicated spectroscopy sequence, and thus can be is a potential biomarker of progression and response to assess with MRI. So finally, the IDH wild-type tumors. So these are what we classically know as glioblastoma. They are the most common and the most malignant astrocytoma, with, as we saw before, median survival is just over a year, and these typically affect older adults. The imaging features are really what we know as typical for glioblastoma: irregular ring enhancement, central necrosis, mass effect, intratumoral hemorrhage, intratumoral vessels, and hyperfusion. This is what we used to know as primary or de novo glioblastoma, and they really just develop out of nowhere. Just as an example of how quickly these can appear is shown here. So this is a patient who came in with a pituitary adenoma, and upon 3 months follow-up after treatment of the adenoma, so the adenoma is gone, but now we have this lesion which was biopsied and turned out to be a glioblastoma. And even looking back to the previous scans on all sequences, we could not detect any signal abnormality. So this appeared within 3 months. So just a final few words on using automated or AI tools for classification. So the idea is, as beautifully demonstrated here in this paper by Rudy et al., that we can use machine or deep learning tools to automatically segment the tumor and subportions of the tumor, extract the various features like we looked at within that we saw in the previous slides, and of course many, many more that can be detected with machine learning, and combine this with all kinds of other information such as clinical information to then come to a prediction of the molecular profile of the tumor and even survival or prognosis. So there are many, many studies out there now, some better than others, where this is being attempted. And this is just an example from our own work where we predicted 1p19q coletion status using only T1 and T2 weighted imaging with an accuracy that was very similar to that of the accuracy that radiologists reached. But of course, much more interesting is that this was much higher than the accuracy that was reached by the neurosurgeons. Importantly, I mean, these numbers are not very, very high, but we used an unselected data set and, most importantly, an entirely independent validation cohort, which is something that you really need to look out for when you're looking at these papers and studies. So to conclude, glioma classification is a very rapidly changing landscape where the latest WHO classification from 2016 is already outdated, and we're on the 5th update now through DC Impact Now working group. The big change here is that IDH wild-type tumors are considered a very aggressive and separate entity. And within the IDH mutated groups, grades 2 and 3 are now more or less lumped together as so-called lower grade tumors. Important to remember that conventional imaging may not be sufficient and that physiological imaging, such as perfusion, can help us identify the tumor's biological aggressiveness. Automated classification of molecular defined glioma is definitely the future. And there are many instances where accurate and non-invasive diagnosis of the tumor genotype and its changes over time matter, now but definitely in the future. So with that, I'd like to thank you for your attention, and please do get in touch in case of any questions by email or through Twitter. Thank you.
Good afternoon. I would like to thank the RSNA organizing committee for inviting me to give this lecture. The objectives today are to first go over the results from several clinical trials that have led to our understanding of the effect of anti-angiogenic therapy. Then I will go over some of the advances using imaging to define response in this treatment setting. Glioblastoma is the most common primary malignant brain tumor in adults with very poor prognosis despite best available treatment. Current standard treatment includes bevacizumab in the recurrent setting, and it is the only FDA-approved anti-angiogenic therapy for brain tumor. Bevacizumab is a humanized antibody against vascular endothelial growth factor. In 2009, there were 2 phase 2 trials reported very high response rates in the range of 35 to 57%. In many of these patients, there were dramatic reduction in the size of contrast enhancement, as you can see in this example below. These reported response rates were much higher than those from previous chemotherapy trials where the response rates have been mostly about 10%. Progression-free survival were also longer than the historical data. The results of these 2 trials led to preliminary approval by the FDA. Several phase 3 trials were then initiated to confirm the survival benefits of bevacizumab. In this phase 3 trial conducted in Europe, where patients with recurrent glioblastomas were randomized to bevacizumab plus chemotherapy versus chemotherapy alone, and the result showed that there was no survival advantage of bevacizumab versus placebo. For progression survival, the bevacizumab treated arm had about 3 months longer than the control arm. How about newly diagnosed glioblastomas if bevacizumab is used as an upfront therapy? In these 2 phase 3 trials where standard therapy alone was compared with standard therapy plus bevacizumab, the results are remarkably similar to the recurrent tumors. Again, no overall survival benefit, while the progression-free survival favored the bevacizumab treated group. Although the results were quite disappointing, from these trial data and clinical experience of the past decade, we have learned a lot more about anti-angiogenic therapy and its effect on brain and tumor. For instance, we know from the initial phase 2 trials as well as preclinical studies that rapid decrease in contrast enhancement observed after onset of treatment is due to decreased vascular permeability. Therefore, the apparent reduction in the size of enhancement does not mean tumor cells are dying. As you can see in this case, even though the enhancement disappears after treatment, there are enlarging nodular mass effect in the same area. This phenomenon was described as pseudo-response. From these trials, we also learned that non-enhancing tumors can be detected on T2 flare sequence. Therefore, most of the clinical trials currently use the RANO criteria, which include evaluation of T2 flare images in addition to contrast-enhanced T1-weighted images to determine treatment response. Yet it is not always easy to detect non-enhancing tumor. I'm sure many of you may have experienced some cases where changes are much more subtle, with growing tumor embedded in large areas of flare abnormality from previous treatment. For example, we can see in this case where there is an enlarging non-enhancing tumor in the corpus callosum on the top flare images. This can be missed when not careful, and even if identified, it can be difficult to measure its size consistently. In fact, using data from RTOG 0625 trial, this is a phase 2 trial where there was high education rate, about 40% for both T1 and flare evaluation. For T1, it is not surprising since we hardly see much enhancement after bevacizumab treatment, but FLAIR is not much better. In phase 3 upfront trial, there is only moderate reader agreement to determine if tumor is increasing or not increasing on FLAIR images. There is a clinical need to identify better imaging method that allows us to reliably detect and measure tumor in anti-angiogenic treatment setting. Many approaches have been developed, and some of these have been tested using data from clinical trials. I'm going to highlight some of these imaging approaches. One early approach proposed by Dr. Allinson's group is simply to subtract the pre-contrast T1 from post-contrast T1 with sequence. The idea is that even though permeability has been reduced in anti-angiogenic therapy, subtle enhancement can be accentuated by subtraction, as you can see in this example. When this method was tested on the phase 2 brain trial data, tumor response determined by T1 subtraction maps show better stratification of progression-free survival and overall survival outcomes. Similar results were also found using the different phase 2 trial data. In this case, a different intensity calibration method was performed prior to subtraction, and the same standard threshold was also used to define tumor in a subtraction maps across all scans. Response assessment using these subtraction maps or delta T1 maps show improved association with overall survival and progression survival comparing to the non-subtracted post-contrast T1 sequence. One major advantage of using subtraction map is that these T1 weighted sequences are already available in standard of care imaging and can be readily implemented in clinical trials as well as routine practice. Perfusion imaging allows us to interrogate vascular dynamics, including cerebral blood volume, which correlates with vessel density and is a marker of angiogenesis in tumor, and also K-trains, which is a marker of vascular permeability. These are the most commonly used perfusion parameters in oncology and have been validated in many preclinical and clinical studies across different cancers. As you can see from the Akron 6686 trial, which is a subset of patients from the phase 3 trial, normalized cerebral blood volume was quickly reduced as soon as 1 day following initiation of treatment. K-trains was also reduced compared to the placebo arm at 7 to 8 weeks, but not right away. This study was not powered to detect whether these changes correlate with overall survival. Perfusion imaging was also evaluated in a phase 2/3 recurrent glioblastoma trial. There was also a greater reduction in normalized cerebral blood volume in the bevacizumab arm compared to the chemotherapy-only arm. Despite this larger sample size of more than 250 patients, changes in cerebral blood volume was not associated with improved overall survival in the bevacizumab-treated arm. There are preclinical data showing high dose or prolonged anti-angiogenic therapy can lead to excess vessel pruning, decreased perfusion, and increased hypoxia, and these changes can drive tumor growth. One recent prospective study using radiolabeled temozolomide in patients treated with bevacizumab showed a reduction in chemotherapy uptake comparing to baseline scan. This goes along with the finding that there is also decreased cerebral blood volume and decreased K-trains following therapy. And this may explain why bevacizumab-treated patients don't have improved survival when added to chemotherapy, and raising the possibility that low-dose bevacizumab may result in better outcome. This remains to be tested. Besides MRI technique, several novel PET tracers have been developed and tested in anti-angiogenic therapy setting. Most notably, FED-PET, which is an amino acid tracer that has been shown to predict overall survival in the trial of elderly patients treated with bevacizumab. Like other amino acid-based tracers, FET PET has much better lesion to background contrast compared to FDG. And as you can see in this example, the tumor shows clear increased FET uptake compared to baseline, while the MRI sequence showed nearly no change. So in conclusion, we learned that from these clinical trials of anti-angiogenic therapy that these agents provide benefit for symptom control but no impact on patients' overall survival. With perfusion imaging, we learned that there is reduced tumor angiogenesis and vascular permeability, and this effect makes evaluation of tumor challenging on post-contrast T1 weighted sequence without advanced processing such as T1 subtraction methods. There's also evidence that anti-angiogenic therapy reduces the uptake of chemotherapy agent in tumor. Since current or future clinical trials will likely be evaluating combination therapy, combining bevacizumab with other targeted therapy or immunotherapy, it is important to find reliable response criteria that can evaluate tumor activity or tumor burden accurately. This requires further testing of many promising imaging techniques in clinical trials, and hopefully these novel methods can help us radiologists to differentiate tumor from treatment effect in our day-to-day practice.
Hello, my name is Ramon Barajas. I am a neuroradiologist at Oregon Health and Science University. I would like to thank the RSNA for the opportunity to discuss the evaluation of pseudoprogression and radiation necrosis, current evidence-based practice, challenges, and future directions. I have no disclosures. We will discuss the clinical dilemma of distinguishing glioblastoma tumor progression from pseudoprogression, the biology of treated glioblastoma, the imaging tools capable of capturing this biology, our current understanding of the clinical utility of these imaging tools, and potential future directions. The current standard of care for treating glioblastoma is maximal safe resection, followed by Stupp protocol temozolomide-based chemoradiotherapy. The monitoring for response to therapy occurs with gadolinium-enhanced MRI. This is an example of the serial imaging findings that can occur with the treatment of glioblastoma. In this case, we see a right temporal enhancing mass that was initially diagnosed in August of 2015. It was subsequently resected and treated utilizing the Stupp protocol. The initial follow-up MRI in December of 2015, after completion of chemoradiotherapy, demonstrates minimal enhancement around the resection cavity that increases greater than 25% in the sum product diameter over the subsequent 3 months, raising concern for preliminary progressive disease, according to current RANO criteria. A follow-up MRI 3 months later shows near resolution of the enhancing focus consistent with pseudoprogression. However, the clinical dilemma occurs contemporaneously at the time of preliminarily progressive disease. The inability to differentiate treatment failure from treatment-related changes by gadolinium-enhanced MRI is a significant clinical limitation that directly affects a patient's care. The imaging appearance of treated glioblastoma represents a spectrum of disease. Chemoradiotherapy often produces a heterogeneous response within the tumor microenvironment. The induction of tumoricidal effects results in disruption of the blood-brain barrier and subsequent contrast enhancement. This has similar appearance to regions of tumor that are insufficiently treated. I think of this dilemma as being somewhat akin to parents trying to correctly identify their twin children. It would follow that the use of biologically specific imaging measures could improve diagnostic utility. In a similar way, these parents have shaved numbers into the children's hair to tell the twins apart. Biologically, insufficiently treated disease is characterized by metabolically active, proliferating tumor with associated microvascular proliferation. Mixed therapeutic response has been described as the presence of metabolically active, proliferating tumor and a background of treatment-related changes such as vascular hyalinization. Some investigators have suggested in this context that the presence of elevated cellular proliferation, characterized by Ki-67 counts, may be a prognostic outcome measure. Conversely, post-treatment radiation necrosis is characterized by the absence of metabolically active tumor with frank necrosis, neuroinflammatory changes including macrophage infiltration, and the presence of vascular hyalinization. However, it should be noted that there is some degree of subjectivity in this assessment, and currently little consensus is achieved. Fortunately, we do have the ability to perform physiologic-based imaging that is capable of capturing some of the biological characteristics associated with glioblastoma progression. Dynamic contrast-enhanced T1-weighted perfusion MRI is capable of measuring blood-brain barrier leakiness. Amino acid-based PET imaging may be capable of capturing amino acid synthesis associated with live proliferating tumor cells. Diffusion-weighted imaging can capture the reduction of molecular water diffusion within the extracellular space due to the presence of many proliferating tumor cells. Dynamic susceptibility-weighted contrast-enhanced T2-star-weighted perfusion MRI is one of the most widely used imaging measures to assess post-treatment related changes, as it allows for the detection of neoangiogenesis-related microvascular proliferation. Given the ability of clinically available imaging techniques to capture biologically relevant information, the question arises, what is their diagnostic utility for differentiating true progression from pseudoprogression? A meta-analysis by Dr. Van de Geeken and colleagues conducted a systematic review and meta-analysis to provide an overview of the diagnostic accuracy of common MRI techniques for assessing treatment response in high-grade glioma patients. The final inclusion was 35 studies comprised of 1,174 patients. A forest plot and pooled results demonstrated that both DSC and DCE MRI performed better than T1 gadolinium-enhanced MRI alone. This suggests that the use of physiologic MRI techniques showed a higher diagnostic accuracy than anatomical MRI in the differentiation between treatment-induced changes and true progression. Among the advanced MRI techniques, MR spectroscopy showed the highest diagnostic accuracy, followed by perfusion-based techniques. A recently published systematic review and meta-analysis by Sorakis et al. Assessed the diagnostic performance of diffusion and perfusion-weighted imaging in differentiating glioblastoma pseudoprogression from true tumor progression. The final inclusion consisted of 24 studies comprising a total of 900 patients. This study demonstrated similar but lower diagnostic ability for diffusion and perfusion-weighted imaging compared to the Van der Geeken study. This reinforces the idea that patients with abnormal imaging findings are roughly 4 times more likely to have true progression of glioblastoma. They also reviewed several studies that utilized amino acid PET to differentiate pseudoprogression from true tumor progression. These studies show that PET is also a promising technique, but there exists marked heterogeneity in published results, and further multi-center trials is needed. In a third study, Su et al. Performed a systematic review and meta-analysis of 9 studies comprised of 456 patients to evaluate the use of multiparametric MRI as a potential surrogate endpoint for the determination of pseudoprogression in patients with glioblastoma. This study demonstrated that a combined imaging approach with diffusion and perfusion-weighted MRI could achieve a pooled sensitivity and specificity of 84% and 95% respectively. However, the finding of various imaging techniques introduced marked heterogeneity in the meta-analysis. It was concluded that multiparametric MRI may be used as a potential surrogate endpoint for the assessment of early treatment response. However, both monoparametric, i.e. just diffusion or just perfusion-weighted imaging, and a multiparametric approach may perform equivalently. Unfortunately, the scope and length of this talk does not really allow me to go into too much details about possible future directions, but several lines of research will hopefully improve our clinical ability to differentiate true progression from pseudoprogression. The importance of standardized imaging approaches across institutions has been recognized and consensus guidelines have been forthcoming. Their integration into clinical trials and hopefully routine clinical care may diminish imaging heterogeneity and allow for future improved study characterization and meta-analysis review. Radiomics and artificial intelligence is a promising approach for improving the diagnostic ability currently not capable by human input alone. Until recently, the contribution of neuroinflammation in the treatment and imaging of patients with glioblastoma has gone under-recognized. In the era of immunotherapy, the development of imaging metrics capable of directly characterizing neuroinflammation may be another approach to improving diagnostic utility and being able to differentiate true disease progression from pseudoprogression. Finally, personalized medicine has been an evolving concept in which imaging measures are starting to be integrated. Future directions could include the use of blood biopsies in combination of physiologic imaging techniques to define personalized biomarkers of glioblastoma therapeutic response. In summary, pseudoprogression is a spectrum of disease induced by the cytotoxic effects of temozolomide-based chemoradiotherapy. Pseudoprogression and true tumor progression are prospectively indistinguishable by gadolinium-enhanced MRI. Perfusion and diffusion-weighted multiparametric MRI approaches and monoparametric approaches may be equivalent. Further prospective imaging studies are needed to validate their clinical utility. And future directions for improving the diagnostic capabilities and distinguishing pseudoprogression from true tumor progression could include standardized imaging approaches, among several other promising lines of scientific inquiry. Thank you.